My name is Felicia D'Adamio, and I am the Regional Referral Relations
Yes.
Specialist for Recovery
Yep.
Ways. I have been in the industry for probably 5.5 years now. Vicky is one of my dear colleagues and one of my dear mentors, and Deanna and Cynthia. We've been all working together in our community to kind of bring awareness and education on what the process should look like for professionals, public safety, aircraft mechanics, flight attendants. I mean, the list goes on and on. So what does the treatment process look like to try to destigmatize what the real idea of it is? Vicky, do you want to add something?
No, I think, Dr. Dara had great questions that I would think people want answers for. And this is be the crew to do it.
So what I'm going to do is Deanna, do you have anything to add?
No, I don't.
Okay, and I think Cynthia's frozen right now. So what I'm going to actually do is I'm going to share a screen, and we're going to kind of, when Dara met with us, we had this vision of putting together really the breakdown of what the treatment world looks like from the moment you make the phone call to somebody like myself, Cynthia, Deanna, and Vicky, and what that process is all the way through. And I guess my first question to the participants on there is like, we're going to go over a lot of things, but to try to make it a little interactive, what I want to do is ask you guys, like, whether it's for yourself or for a loved one, or whether it's something that you've experienced, what are some of the questions that you have? What does it look like? And what is the first thought that comes into your head when someone says that they are seeking help for either mental health services, trauma, depression, anxiety, PTSD, substance abuse? Like, what is the first thing that pops into your head? And while you guys maybe put some things in the chat, I'm going to share my screen right now. So what we want to do is we want to help you destigmatize. The goal in this presentation is to remove the association of shame and disgrace with mental illness, and what does that look like? According to the Mayo Clinic, there are signs for seeking treatment. And right here, we wanted to talk about what these signs look like. They're marked from eating and sleeping patterns, inability to cope with with problems and daily activities, feeling of disconnection and withdrawal from normal activities, unusual or magical thinking, excessive anxiety, prolonged sadness, depression, thoughts of statements of self-harm, substance misuse, extreme mood swings, and excessive anger and hostility or violent behavior. Vicky, I would love for you to share what you've seen in your experience about when we get those phone calls, like what happens? What do you see?
It seems that we seem to get calls from people who have been in the field 10 to 15 years. And a lot of the comments were, man, I could handle this for 5 years, 10 years, but now I can't handle it anymore. I go home, I pull in the driveway, I don't want to get out of the car. My health, I can't sleep. My health is getting bad. I don't understand why I can't handle everything the way I used to. And that usually happens a few years in. It happens a little sooner now because a lot of people who are entering the field were in tours of duty. And then when they come home, they go into service. But for the most part, when I have been dealing with most of the first responders, they've been around, they've been working for 10 years. They start getting medical complications, some high blood pressure, digestive issues, weight fluctuations, and they start to isolate more and more and more. And that's kind of a typical person who starts to reach out and go, I think I need to figure out what's going on. And then it gets very quiet, just like that.
Yep. So what we want to do is, we want to talk about, a buddy check, right? What does that buddy check look like within your departments? Who is, kind of taking lead in all of that? The idea, we wanted to be a little bit funny with the memes about like, don't leave your buddy out in the cold. And again, Vicky has been doing this for a really, really long time. I look up to her tremendously. And so, what have you seen in your history, in your past, with what it looks like within certain departments, whether it's the fire safety, whether it's, border patrol, what does it look like in your experience? What have you seen within the peer supports that you've worked with on how they operate? What does that look like? And then these participants chime in.
I mean, there's all people reach out at all different levels. Some people reach out through their EAP. Some people don't even know who they have for EAPs. Some people reach out to peer support, or within some organizations are very good about providing different kinds of services for their people. Some are not. Some people self-refer. Some people don't want to deal with anybody at all. They just want to fix it themselves. So there's not a real common pattern. There is just a real common need with trauma and depression, anxiety, and the symptoms that are presenting. How they get to us is always different. Somebody said most EAPs take too long to get an appointment, and many department employees have no idea. And that's very, very true. And sometimes EAP, you'll get 8 free sessions. And I've had people say, I called my EAP because I couldn't sleep anymore, and I could get in October 15th. And that's too long. And right. I work within the EAP systems to try, we go in to work with EAP systems, and some of the systems go from 8 sessions to 12 sessions, but that doesn't do any good. The first session you can get is on the 15th of October. So there's some blocks to trying to, when you finally get the courage, or you finally get to the place where you want to reach out. I think you might have, I'm encouraged that people are finding that peer support is getting better, EAP is getting better. They're getting to be more resources. The websites, there's more treatment options, and there's 1 week, 2 week, month-long different retreats. There are a lot of resources out there, and there needs to be a lot more. But I think nobody comes the same way. Asking for help.
And I can absolutely agree to that. I think, and we're going to go over what we also want to do as well, which will be starting the next slide, is what are the different levels of care? What does that look like within insurance? What does that look like? What are when you are paying for insurance through your employer, what should automatically be offered under the Affordable Care Act and all of that? What is that? What is it called again, Vicki? For whatever reasons, I'm trying.
Tiger Act.
The Tiger Act is only in Arizona. Vic, what is it?
What, parity?
The parity.
Yeah.
That's what I'm asking for. So Jason also put, unfortunately, peer support in most agencies are limited to only a few trained people. So when it comes to buddy checks or peer support, it falls on just a few select team members. With a large agency, they're not always able to fully assist with getting through the problem, which is, I agree with that statement as well. And so let's help educate you guys on what
The
what
level
are
of
the levels of care, right? I think that's the most important thing. Like when I speak to employers or when I speak to family members or whoever it is, I have to remember that the people that I'm talking to are not in the world that we're in. So what does that mean? What does that entail? Educating our community and our partners and everybody involved, what does that look like? So this is what inpatient looks like. You have a couple different ways that you can utilize inpatient treatment. One of those is a level 1 stabilization. Deanna and Cynthia both, they work at an inpatient stabilization. So what does that look like? It's a level 1 behavioral health hospital. Who qualifies for a level 1 behavioral health stabilization? And either Cynthia or Deanna, I think that you should touch a little bit on that.
So Felicia, before you guys do that, would you mind actually going through each of you and telling people a bit about your background, each of you, and then where you work and what you do? That'll be great, if you don't mind.
Yeah, we can do that. So I think the internet and everybody has gotten on and a little bit better. So again, my name is Felicia D'Adamio, and I am the Regional Referral Relations Specialist for Recovery Ways. Recovery Ways is a program that's known nationally. We do a lot of work with professionals from public safety to, like I said, flight attendants, railroads, all blue collar union employers. We're a duly licensed facility. We're located in just outside of Salt Lake City, Utah. And we're duly licensed. We have a mood disorder program that is residential. So it's after this stabilization piece, right? And it's typically between 21 to 28 days. And we're going to go through that a little bit more, but we offer all levels of care. And Vicki and I have been working together for a while. I've been in this industry for 5.5 years now. And I think for me, what has happened in the education that I've been able to accomplish is I've been able to meet people all over the country, whether it's EAPs, whether it's clinicians and people that I have found as mentors to kind of help guide me through what I do now. And Deanna, only because you're right.
Hi, guys. I'm Deanna Matos from Copper Springs Behavioral Health, and we have 2 facilities here in Arizona, one on the East Valley, which is in Gilbert, and we also have another facility in Avondale. We have a total of 144 beds, having 72 at each facility. We are a level 1 acute care hospital, so we take the patients that are on that high acuity. So if you would go to the emergency room for a heart attack, chest pain, anything major, that's what we do in the behavioral health realm. We are a voluntary facility. We take patients 18 and over. We have a full continuum of care. So we go all the way from level 1 acute care inpatient all the way to PHP and IOP. And we also have virtual IOP available as well. We also do have a specialized track for our first responders, active military, and Cynthia would go more into that to discuss that program. But if you guys have any questions or need anything with that level 1 acute care that we can help you on, please always feel free to reach out to any of us on the panel, and we can actually help you navigate through wherever you need and give you the resources needed so you can have that smooth transition.
So I've been in the behavioral health care field, as you can probably tell, for 25 years. So the last 10 to 12, I've been specializing more with first responders because I saw the need and the lack of options in the different kind of programming that was needed. And the more you work with first responders, the more you realize that it isn't, you don't need traditional services, you need specialized services. And there's a lot of reasons for that. But I started working with different facilities, and I've been with Recovery Ways, and we were able to build out, because one of the things I've always felt was important was you have insurance, you're injured in some way, and you should be able to use your insurance to get your needs met.
Mhm.
So we can do that within a facility organization, whether it's telehealth or intensive outpatient or inpatient or retreats, or what we designed was this last couple of years because of COVID, because a lot of times first responders can't be gone for 30 days, 45 days, longer lengths of stay, but 2 weeks is doable. They can be out of the service area for that period of time. So then the question is, well, can we do in 2 weeks what we need to do? So we do have to assess pretty carefully on the front end to make sure that it's the right thing for people. But there's a 2-week program that is now available, which, 2 weeks is much better to be off site than a longer period of time. And that's based on resilience, and insurance can pay for that also, or will cover it. So part of what I've been doing in the last 10, 12 years is helping to see the need, try to help with training where like the EAPs or the peer supports, we go to a lot of peer support training, the support for whoever's doing the training. And then I work in admissions and intake and try to do assessments to make sure people end up in the right place and have the right choices and the right resources.
So that's Cynthia Vargas, and she's one of my colleagues. She's actually our Help for Heroes rep. And she's the one in charge of getting our active military, first responders into services at Copper Springs. She is actually the one that handles all our first responders, gets them into programming, gets them from the moment that she gets a crisis call. And she is our primary person for that because she is former military and she has a great understanding of first responders, what their needs are, why they don't come to look for services. So Cynthia actually gets these first responder calls. She works hand in hand with our providers and does a smooth transition from the moment she gets this crisis call to trying to get the patient into our facility and getting them the services that we need through our Help for Heroes programming. In the event that they are not a good fit for our facility, we also strive to do the best that we can to get them to the facility that they do need to get to, whether it's an extended level of care going up for residential, or if we need to step them down and send them to a different facility. So we also work with a lot of people in the community to try to get them these services. And in our first responders programming, our programming could go up to 21 days with our heroes to try to stabilize them, get them everything that they need. And from there on, help them with the transition of going into inpatient, lowering them to either partial hospitalization, outpatient, and then bringing them into our, or someone else's residential treatment. But that in a nutshell is what we do in at Copper Springs. And if you guys need any information, we also have brochures that we can send out or send to Dara to send out to everyone that's on the call so you can see detailed what we do at Copper. And
so I think we should just get back to, because now that the connection is a little bit better, let's get back to explaining what inpatient is, right? What does that look like? And what are the 3 different levels? Part of the things that Dara wanted us to disclose of like imagining walking you through from the very first phone call and what does it look like depending on what services you're seeking, right? So we'll try to do it as, as simply as we can. Obviously, we could talk about this for a really long time, and we can get into more detail with you, but we really just wanted to paint a bigger picture, a baseline for it. And so this is what an inpatient, the different levels of what inpatient would look like for somebody. And the psych stabilization piece is huge. I mean, if you have someone that's actively suicidal or homicidal or self-harm, anything like that, that would be your first step for somebody that has finally gotten to the place where they're admitting that they are thinking of suicide, and they have a plan in place, right? And then the next step would be a detox. If somebody has been self-medicating on particular medications to help with their depression or their anxiety, they may not have an issue with a substance abuse, but what may be happening is because they're self-medicating, they might still need to go through a detox process. I mean, you have benzodiazepine, you have alcohol, you have different medications that are extremely dangerous for you to go through a withdrawal process by yourself. So people don't realize that alcohol and benzos, when you're prescribed it for medication for anxiety or not, you're self-medicating because you think that it makes you feel better. You could have a seizure, and most of us know this, but not everybody knows that you can have a seizure and with the withdrawal process, with going through alcohol withdrawal and a benzodiazepine withdrawal. And that is what a detox would help you set up. Now, depending on your history and depending on the amount and the intake of like what you're consuming, that depends on the length of stay. It could be 3 days. It could be 7, 8, or 9 days. That's why it's so important for us. One, respect your confidentiality, but understanding that the more information that we get from the individual, the better off you're going to be, because then we can be more transparent on what is this going to look like? What is your medical history look like? What kind of complications have you had in the past? Vicki, do you want to share a little bit, or am I doing?
No, that's absolutely accurate.
Okay.
I mean, sometimes one of the things, kind of the common things we see are with the sleep disturbance, it's Ambien, and then there's complications often with high blood pressure, or somebody will start taking a medication 20 years ago and they're still taking it, but they've just added more and more and more medications on without
Prescription.
without getting off of the other ones. So by the time a lot of people say, oh, well, I'm on an antidepressant, I'm on an anti-anxiety drug, which could be Ativan, Valium, Xanax, Klonopin. And by the time it's a cumulative kind of thing, by the time some people decide to reach out for help. And that's why often they end up in detox. You don't necessarily have to go to detox if for PTSD, trauma, anxiety, those diagnoses, unless you've been medicated on those drugs, and so you could detox and then go into treatment for PTSD.
Right.
They usually go hand in hand. So first and foremost, you would have to go through the process of detox, and that can go anywhere from 3 to 10 days, depending on the severity of the patient and how much they've been using substances. After that, once that's under control and they have gone through the process of detoxing, whether it's medically with medicine to help alleviate a lot of the symptoms, or if it's more of that cold turkey while being monitored. Then after that, once you're done with that detox process, then we can actually go into the underlying issue of what is it that's bringing that person to using the substances with the mental health underlining. So those are the levels that we have. More so stabilization after we stabilize, or detox, then we stabilize. And then after that, we go and dig deeper into what is it that's actually bringing this first responder to do the things that they're doing. What is the trauma behind it all? And that's like the services that we are able to provide as a level 1 acute care hospital.
Right. And then from there, it steps into like, you know, going into a facility for 7 to 10 days isn't enough. I mean, the way that I look at it, it's like putting a Band-Aid on a stab wound. You can't do that. You need to stitch it up properly, right? So what does that look like? Depending on the individual, there's multiple services, but depending on the type of crisis that you're in, like the last thing that we want to see is somebody in that type of crisis mode, but it happens because people stay silent for way too long, and then they're scrambling in trying to get the person help at the highest level. And it's almost like, okay, but that's just going to put a Band-Aid on it, right? Well, now comes the work, and the work is the resident. It can be, not always, but a lot of times it can be the residential care. And Vicki, I would love for you to share about the residential care.
Well, so residential is 24 hours a day, 7 days a week. And it is covered by most insurances. It usually includes psychiatric if it's indicated. And it's usually performed by master's level therapists. And you want a place that's credentialed by either CARF or the Joint Commission.
Well, and you also want to make sure, not to interrupt you, but when you're calling, if you're self-referring and you're not relying on your EAP or your peer support because you don't want them to know what's going on, or whatever the case may be, you just don't want to do it and you want to self-refer, what you want to make sure is you need to ask particular questions about the facilities that you're calling, because what's happening in this day and age is we have a thing called Google AdWords. So you type in treatment center near me, right, in your Google platform, and you're getting a bunch of paid ads from facilities all over the country. They're not necessarily near you. They're not necessarily mental health only. They're not, there's so many things that, in my opinion, you have to vet and you have to ask those questions. Are the psychiatrists that are there full time? Do they carry their own caseload? Are there master's level clinicians? Are they trained in mental health? Are they trained in substance abuse? What is their background? You have to make sure that you ask those types of questions, because you don't want to end up in a place that you have no business being in. Sorry to interrupt, Vic. I just wanted to share that.
Yeah, that's good. That was about all I had to say. So.
Oh, well, sorry, I didn't mean to interrupt.
To piggy on that, if you guys, we are very well versed in the community, myself, Felicia, Cynthia, Vicki. We have a lot of resources that we do have put away that we have collected throughout the years. I've been doing this for 13 years. So we do have a lot of information that we have, that in the event that you get caught up or overwhelmed with all the information that you do see online, please reach out to us and we will help you navigate through those facilities.
They're available nationally also. So, you know, there are facilities in all 50 states. And we can help if you want help to figure out if something that's closer to your home, then we can help with that.
The other thing that we want to go over is the different outpatient levels of care, right? So what does that entail? Depending on what your need is and what's going on. You have your PHP, your day treatment, which is programming 6 or 7 hours a day, 5 days a week. It's a little bit, it's not as structured. You could do it from home. You can go to a facility that's near you and walk into the building and have your groups and have your individual and have your appointments with psychiatry. The other thing that we have is not just us, but insurance in general, is that you have your intensive outpatient program. But now with COVID, you also have the virtual IOP where you can log in 3 days it's 3 days a week, 3 hours a day, right? So you can protect that anonymity, on top of that, where maybe it doesn't work with your schedule to go in person. Maybe you don't feel comfortable walking behind into that building because it's too close to home or it's too close to where you work. Well, the virtual piece is an added bonus because you can log in and you can be a part, and it's interactive, and you can have that protection with your anonymity. The other thing too is individual therapy, general outpatient, going and seeing a therapist individually one-on-one. So there's so many different ways that you can seek services to maintain your mental health. And that's what we want to kind of give you in the structure of like what that looks like. That's typically covered by your insurance. To move forward, sorry, let me see. This is a little bit of a breakdown, right? How many, and this is an average, right? Because every insurance is different, but we want to show you what an average length of stay is when utilizing insurance, and what we see on our end as in-network providers. What is it that we see? What is it that we do? And how many sessions do you typically get out of all of it? So this is just a breakdown that I think is really good for everybody to understand. So preserving your identity. Vicki, I would love for you to share a little bit about what that looks like and what that entails, and how sensitive, as at least what's people like us on this panel, of how we understand why it's so important. But if you could share a little bit, Vic, or just give your feedback, I would appreciate it.
Yeah, well, some people don't want to go in because they don't want to go out and receive services because of the stigma, there's shame, there's all of the feelings that go with that. What we have found, what I have found nationally, is often people will want to travel out of their living area so that they don't see anybody they know, and then they'll come in, they'll feel comfortable. If you're in a place that where you feel a trust, then you'll do the work that you need to do. And often when people get to that level of care and trust and do the work, the stigma lowers, and then they're more willing to access services in their own area. But sometimes they're not. People want to start out with virtual IOP. They want to do it in their home. And it doesn't really matter how you start. It's just more important that you do start. The one thing I also wanted to mention is when we do a lot of referral work, we vet the people before, so that if you call and ask for someone in Charleston, before we will give out the information on that, we will call and make sure that they know how to deal with trauma or however somebody presents, to make sure that we're getting at least as vetted as we can do resources for them.
And like we just wanted to share, it's really important that we protect the anonymity, right, of the individual, regardless of what your background is, but even more sensitive to this case. And what is an ROI? What is a release of information? What does that entail? Who does that grant access to? It only grants the access to whoever if you allow it. So you can sign, you have the right to sign for a limited ROI, for full access. You have those rights, and you should be able to look and see when you're filling out the person's name for the ROI, of checking the boxes of what kind of access you want them to have. We can never confirm or deny whether or not somebody is in our care, ever, and then even as far as like walking into a program, right? Coming in, What does that mean? Are you walking in from the second say you call Vicky and you're looking for resources and she lines you up with a program that understands the environment of what public safety entails. What does that look like for you? What are you going to walk into? Ask those questions. Let that person, like myself or Deanna or Vicky, be very transparent of what that process looks like. It's not so scary. You're not going to get a cavity search. You're not going to get stripped down. I mean, you're not going to feel like a prisoner walking into a residential property. That's not what it looks like. It just doesn't. Not for places that understand that, not for places like ours that we would work with. That's not how we operate.
Even also we have protocols in place at the facilities that when a first responder does call our facility or their peer calls our facility, they come into the hospital, we give them private rooms, we do assessments, put them with like-minded individuals, with first responders, and not typically put them in with general population. So we do have certain protocols in place to keep that identity, preserving that identity, and making the transition and the process smoother, so you don't have to feel that everybody knows you or someone's going to see you out in the streets and they're going to know who you are and you were at a facility. No, we try our best to actually separate and differentiate so you can have that privacy you need and get the services that you need due to that privacy.
Vic, do you want to share anything?
No, that's good. I think we can move on.
Do facilities and programs help with FMLA paperwork? What is put on FMLA paperwork, right? What does that mean? So it's our job to know and to work with the individual of what needs to be on it and what doesn't. I mean, I know within a lot of the companies that I work with and the organizations that I work with currently, I know what needs to be left off of FMLA paperwork or the absentee certificates or whatever that needs to be sent to HR. I work with the individuals on protecting that, but also working with my case management team to make sure that the paperwork is filled out appropriately so that you can continue whether you qualify for some of your money, all of your income, regardless, saving your job, whatever it is. It's our job to work with you and work with those departments or organizations to understand and educate ourselves on what is their protocol or what are their laws within the state. What does that look like? Are they not allowed to have a diagnosis of substance use disorder? Does it have to be mental health only? What does that look like? So that's how we work with the individual or work with the department to figure out what that needs to be. But we absolutely will do that the way that it needs to happen, to protect that person's job and their security of their livelihood. Vic?
Nope, that's absolutely. Some
Right.
people don't use FMLA or short-term disability. A lot of first responders have banked PTO time and they just come in and use their vacation or their PTO time. So you can help with whatever you need.
So coverage and cost. These are the things that we take a look at, and these are your options, right? You want to find a place that can take, typically you want to make sure that when you call a facility, and they are very transparent of, oh yeah, we can take Cigna. It's like, no, are you in network with Cigna? Those are the types of questions, because people will say, yeah, we can take it. But what they really mean is they can take it and they can take it out of network. They're not necessarily in network. The other thing that you can do is if you're speaking to an IOP or a residential program, any type of program, call the insurance on the back of your card. Make sure that they're in network to keep that cost down. You know, I mean, at the end of the day, you still have your deductible and your out of pocket for in network that you can work on with payment plans and so on and so forth. But if you really want to make sure that whatever place you're talking to, whether it's a therapist, whether it is, like I said, an IOP, a 2-week program, a trauma intensive program, a residential property, a psych stabilization, make sure that your insurance asks that question. Not can you take it? It's are you in network, right? Because you don't want to get hit with that financial responsibility at the end. So it's all about knowing and identifying, like asking the questions flat out.
Majority of the businesses out here, facilities also do verification of insurances. So you can also ask for a VOB, which is verification of benefits. They can run that at the facility and they can actually give you a breakdown of what your cost will be, what your out of pocket would be, what your deductible would be. A lot of times you don't have it. Majority of times you do. So whenever you call any type of facility, ask them for them to run your insurance. If you don't do it on your own, calling the insurance company yourself, tell them to run a verification of insurance for you, and they can actually give you a breakdown of everything that you will be liable for if you are liable for anything.
Right. Vic?
You know, it's so an example, if you choose to go to a place that's in network, the in-network facility patient charges for your deductible and your stop loss or your out of network. If you go to a place that's out of network, I can give you, like this last week, I had a couple of examples where a person from Illinois had Aetna insurance and they were looking at a certain place nationally. And they said, yep, we'll take your insurance. And then we always ask for 30 days of coverage. So we'll take your insurance, but it'll be $17,000 out of pocket.
Right.
I had another one that was Blue Cross Blue Shield, and it was kind of the same thing. Yes, we'll take your insurance, but you know, your out of pocket cost is going to be $12,000. So those are the questions that you want to have, and they need, let's hope that they disclose that before you make the admission. In the old days, it didn't always happen. I think it happens more often now, that there needs to be some clarity before you make a choice.
And for us, it's just really important. Like for me, if I can help anybody understand this world, because we live, sleep, and breathe it, right? Like if I can help anybody, or us can help anybody understand this world and how to ask those questions so that you can get the right answers, so that you know what the expectation is from the very beginning. What does that look like? You know, then we've done our jobs, you know what I mean? And again, if you guys still don't know and you have questions, reach out to us. We'll help guide you. We'll help tell you in our experience what we know, what it looks like, the more questions to ask. I mean, at the end of the day, that's all we want. We want to make sure that people are getting the best care possible within their means, whether it's insurance dependent, whether it's looking for, whether it's cash pay, whether it's going through the VA. What does that look like? Do we want to make sure that at the end of the day, you're going to get the services that you deserve to have within your means? And that's it. That's all we care about. I can speak for us on this panel. That's all we care about.
Besides representing our facilities, we are, at least the people here on this panel, our number one focus and priority is to get you the help that you need and the resources that you need, despite whether it's our facility or someone else's facility. Just get you the information that you need. And it's the places that we most likely trust and know in the community, and we feel comfortable enough to refer people to, that we know that they're going to get the services that they really need and the help that's going to actually help them go to that next level of getting better and just being able to function as a normal person in our community. So please, our information is going to be on the last slide here. Please don't hesitate to reach out to us. Let us know if you need anything. If you need anything specific with our programming, let us know. Cynthia, like I said, she's not on anymore, but she is our expert on our health referrals programming, and she can actually help you navigating anything Copper Springs that you guys want to know. Vicki, again, on our panel, is very knowledgeable with the first responders community, and she can also help you out. And Felicia and myself, we do work with a lot of people nationwide. Anything that we can do to help you get to where you need to get the information that you need to better yourself, please don't hesitate to reach out to us.
And again, we apologize for any of the mishap in the beginning. Of course, that was like my biggest fear, and it happened. So hopefully we can laugh about it later, but right now I'm gonna go cool my face off because it's probably burning hot. But Vicki, is there anything else? Dara, do you think, are we missing anything? Did we go over like everything that we wanted?
You did a comprehensive job. I think that, one of the hardest things in this field is figuring out how do you pick a treatment program, like which one would work best for me. And you all are the treatment referral experts. As you guys were talking, I got a text message from someone saying, I am partial to Chateau recovery because, I had a good experience with Chateau. Well, guess what? You guys, refer to Chateau as well. In fact, Vicki used to work for Chateau, right? Felicia also did work with Chateau. And so these are great things. You guys, you're so immersed in the field that you do, that I have no fear that you will find the best program for somebody based upon what criteria they have and what they need. And I've reached out to all of you many times previously to say, hey, look, we have this person with blah, 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 blah. And it could be, honestly, even if you weren't here, I would say this. It could be any time of day or night, and I could always be assured that you guys will pick your phone up and you'd get back to me. And then you'd be able to at least say, all right, we got this, and we're going to do this. And then you'll follow up and say, hey, this is what happened to this person. And I just love working with you guys. You guys are so great. You're great at your skill.
I don't know boundaries, so thank you. I'm like, I don't know.
Well, that's a prerequisite for doing good in work. Have no boundaries.
Is there anything else? Does anybody have anything else to share? Does anybody have any questions? My goal is to we really just wanted to help Dara's vision of like painting a full picture of what a treatment process is like. There's so much more to it, and we could have went on for probably another hour, but you would have fallen asleep. So why don't you just hit us with the crisis and then watch us work?
Yeah, right. That's exactly right. If you all don't mind, what I'd like for you to do is to actually go into the chat box as well, and then just kind of look, and you guys could make sure well, I'm sure Ivor could also share your contact information with everybody, like you have it up here. But we will say thank you, and unless you guys have anything to say, I'll try to close the day out a few minutes early for everybody who has been awake since 4 o'clock in the morning doing stuff. Anything else on your side, Felicia?
I don't think so. I just wanted to make sure that what you had in mind, we were able to provide. That's all we care.
This is great. And I think for people, I guess if I had one more question, it would be, there are people that sit on the fence wondering, should I go for treatment? Should I not go for treatment? Like, how do you make that determination on if you need help versus, you know what I mean? Because you guys have been there.
So what I can tell you is something that I work for them. So I'm a little obviously biased, but something that I absolutely love that I do a lot, and a lot of my EAPs reach out to me for, is if you have an individual or if you yourself are struggling, we have the capability to do what we call a mobile assessment, but you're not really quite sure what you need. The mobile assessment is done on the phone. We can set up the appointment with either Megan or Maureen, and they ask you questions. It's typically between 30 minutes to an hour. It honestly just depends on what you have to say. But we ask the questions and they go through a bunch of questions based off of the ASAM criteria, right? And then from there, we can provide that recommendation for you. We can say, based off of what you're reporting to us, you would really be better served looking into an IOP. Why don't you start there? See if this helps. This is the things that you need to address, or let's focus on working on getting you a psychiatrist in your area that can prescribe you proper medication for your anxiety. What does it look like? So if you're questioning, that's one thing that I can say, at least it doesn't have to be like you're going to come into recovery ways, but we can provide this assessment service for you and we can do it over the phone. Why not? Call me. I can set it up. If you're not sure, I'll help you try to figure it out. Or my other question to you is, what do you have to lose at this point? Right? Because I've seen time and time again, we all have, every single one of those on this panel. I can promise you a lot of people on this participation, all the attendees, I've lost people either in the place of business that I work or people that I've truly cared about as friends to suicide. So what do you have to lose at this point?
Yeah, 100% right, man.
You're talking
100%.
about your life or the individual's life.
Yes. We have we have a really amazing Caribbean turnout here to this year as we did last year, which I'm very grateful for. And we have a question here from Jean Joseph that asks about services with first responders in the Caribbean region. Are the services only accessible to people in North America, or is it accessible to people within the Caribbean region and Belize and in other places as well?
Vic, I'm going to
Well,
put that on you.
Yeah, well, so the question would be, first of all, what kind of coverage do the participants in the Caribbean have? Do they have private insurance? Do they have services that, most of all of our organizations would be open to contracting at a financially feasible rate for an IOP or even webinars. Some things can be created, but if there is private insurance with people who have services in the Caribbean, then it's a done deal. Like,
okay,
private insurance.
If people are going to pay out of pocket, Vicky, or any of you guys that might, well, Vicky, you have a lot of experience in different agencies. What is the average cost for treatment that somebody would have to pay out of pocket?
And that's an interesting question, because that can vary all over the
a range.
Depends on the facility. So if majority of the time, the level 1 acute cares can range anywhere from $900 to $1,200 a day, depending on the length of stay that they're gonna stay with. A lot of facilities have extra charges for doctor's fees, but it's like a lot of these facilities, when you do talk to them and you're coming from somewhere else, or you have on a tight budget, some of them have scholarships, some of them work with you, some of them go into their business office and make payment plans. So just because you don't have the funds to go and get the services that you need, don't let that stop you from talking to someone and actually trying to navigate the system and asking them if they do have resources or other forms of funds that can actually cover their stay at a facility. There's other programs that I know that sponsor first responders and actually bring them into these type of facilities. So don't ever let the no insurance or out of pocket steer you from not getting the help that you need. You know, all these facilities have things in place that they're going to do whatever it is to get you the help that you need to get.
If you're talking to the right people.
Yes.
Yes,
If
right.
you're talking to the
And
right
that's really honestly where you guys come into play, right? Because you'd be able to help figure out if there are scholarships available. Maybe Doug Monda's organization might pay for something. Like you may have other ways to be able to get help. So I think that's true.
So Gary just asked a question real quick, and I know we're cutting it a little bit close, but I really think it's important to answer it from our perspective is, do people ever hear, and even you, Dara, I mean, you're the doctor. Do people ever heal from PTSD and chronic stress, or do they just learn to cope? And when I read that, what I thought of is our occupational therapy with our sensory. Vic, can you answer a little bit about that and talk about that a little bit? And then Dara, from your perspective, obviously, as well.
Yeah, well, I mean, my experience is if you, whatever level you do, if you do the trauma work, you don't have to keep repeating and repeating and repeating. You do the work, you complete it. There may be other levels. There may be other things, but coping type of things, there are also coping, like we have self-regulation coping skills that, because life goes on, like there's always another problem that we seem to sign up for. And if we get, when we, like one of the added bonuses of getting trauma treatment is learning tools to self-regulate. And then a lot of times those same tools work when you go back to your family, or you go back to your workplace, or you go back to life, kind of thing. So I truly do believe that people can recover and that people can learn to cope. Both. The answer is both to me.
Dara.
I see PTSD is very much like a spectrum, like how we have a developmental disability spectrum of disorders. You know, some people have not too severe PTSD where they can heal from it and move on, you know, and hopefully it wouldn't bother them again. And some people have chronic PTSD symptoms and issues that will last the rest of their life, like a grief process. But you do learn how to manage and how to cope and live with PTSD. So it becomes something that you have in your life, but you'll be able to live a fulfilling life with PTSD as a diagnosis, you know. But I truly believe that it's a gradient kind of question, as opposed to just saying it's one fixed diagnosis and here you go. That's what, you know. It's not so simple. And I think often about people with schizophrenia, for instance, that take medications. And some people who have severe symptoms of schizophrenia say, well, the medications I take, they don't make my voices go away, but they make it more manageable. They mute the voices down so that way I can live my life a little bit more, you know.
Quality of life. Yeah.
Quality of life, right?
Yeah.
And so I think that we have tremendous tools in place to be able to help people recover, to get to the place of good qualities of life. And I think that's very promising in all of the work that we do.